on this auspicious day of Guru Purnima, which is a original Teachers' Day as per Indian culture. So, and I would request Dr. Rakhi and Dr. Ankur to take the stage and inform the all the esteemed delegates about this initiative of Indian Society of Pain Clinicians.
Thank you, sir. Good morning, everyone. I'm Dr. Rakhi Gupta, consultant pain physician in Lucknow. I welcome you all to the 6th ISPC Online Pain Gurukul, which is an educative initiative by the Indian Society of Pain Clinicians to educate all the residents of anesthesia, the people in pain management courses, and everyone who wants to pursue pain in anesthesia branch as well as others. This is the third webinar in the Percutaneous spine endoscopy series. Earlier, we have had Dr. Anurag sir's presentation on basics overview of spine endoscopy, as well as Dr. Deven sir's presentation on overview of MRI basics and instruments used for spine endoscopy. Our coordinator today is Dr. Ankur Jain. He is MD PDCC from BHU, Varanasi, and is presently working as a specialist in pain medicine at Emirates Hospital, Dubai. Hello, Dr. Ankur, and I would like to introduce our speaker today.
Lot of thanks to Dr. Anurag and Dr. Rakhi. I would like to also thank all the dynamic pain physicians of India attending the webinar for their courage and hard work in relieving the pain of the COVID-19 crisis. Last week, we have a webinar by Dr. Devendra on how to read a MRI spine and different equipments dealing with endoscopy. Now, in continuation of that, I would like to call our speaker, Dr. Sidharth, to talk on transforaminal approaches to percutaneous spine endoscopy. Dr. Sidharth needs no introduction. As far as I know him, he is one of the dynamic pain physicians of India who has contributed a lot in taking our pain specialty to higher levels. Dr. Sidharth is working as an associate professor in DY Patil Medical College at present, and he is also a consultant interventional spine physician in various medical colleges and various pain centers all over the Navi Mumbai. And he is also a secretary of Indian Society of Anesthesiologists, Navi Mumbai City branch, as a joint secretary of Indian Society of Pain Clinicians, and is a co-founder of Mumbai Pain School. He has got about six international publications till now, and is one publication, he has a patent on that publication. So again, I would like to invite Dr. Sidharth to continue his speak. Thank you.
Thank you so much for the kind introduction, sir. I will again make my presentation full screen. So just can you see it now, full screen?
Yes, we can see it.
Yeah, so we can see it.
I'll start. So thank you so much, Dr. Anurag sir, Dr. Deepak Thapa sir, for realizing the vision of Professor V. Rastogi, and what better day to give my talk than the Guru Purnima today. And also our senior physicians from all over the country. Welcome, colleagues. Welcome, everyone. Thank you, Dr. Ankur, for the kind introduction. And I would like to begin my talk now. This is the talk is on
Dr. Sidharth. Dr.
Yes.
Sidharth, I would request that perhaps we can wait few more minutes because people are very fast joining.
Sure,
perhaps 5 minutes.
Sure, sir. I will like to wait. I will minimize my thing. Let me
No
know when to
issues.
start.
No, just in the meantime, you please tell us about the this initiative of Indian Society of Pain Clinician a bit.
Yes.
And why it is important for the residents of anesthesiology also.
Great, great. So what I will do is I will inform about why this society was formed and why we did it, and what is the features and what differentiates us from the rest and how we are different, and what is our aims and objectives. So we very well know that pain medicine is a very upcoming specialty, but it is not upcoming from today. It is upcoming from 1985. So when Professor Rastogi, probably he started or attended the first pain conferences, and Professor Rastogi was the one who was the founder members of ISSP as we know it today. And slowly the branch progressed, where the formal teaching was started only in 2008 when Professor V. Rastogi he started the PDCC courses at BHU, and also at SGPGI, Professor under leadership of the courses were started. And these two centers were the torchbearers of the formal education in pain medicine in India until very recently, when the other courses were also started. So while all this was happening, there was a class of pain physicians who did these courses, and they were qualified by virtue of being 1 year full-time trained postdoctoral certificate course in pain medicine and palliative care. And the nomenclature was also heterogeneous at that time. So some people have pain management on their degrees, and some people have pain management and palliative care, and pain and palliative care on their degrees. So it was the need was felt to propagate formal training, so that this branch can gain a strong foothold, and the patient safety and other things can be formalized, and more physicians can be given this chance to study and come forward and practice pain medicine in their respective areas. And I think ours was the pioneering branch, which pioneering society, which took this initiative, and as a result, now the other bodies also have taken fruit. And FIAPM was then formed by the Indian Society for Study of Pain, and they tried to formalize the training as well. And these efforts, along with efforts of many from even from Indian Society of Anesthesiologists, like Dynamic Secretary Dr. Naveen Malhotra, and with other collaboration of our own you can say members, and this vision of Professor Rastogi has now been realized in form of a DM in pain medicine. I still remember running from pillar to post for just making one proposal forwarded to the MCI from BHU for the DM. And I would like to thank Dr. Ajit, who has probably taken the lead in this scenario. So this is a brief history. At present, we have our website functional, where you can find all the details about the society, what it has done till date, whatever it is doing in the future. So under the presidentship of Dr. Deepak Thapa from GMC Chandigarh, so we have and able leadership of Dr. Anurag Agarwal, we have now put up this educational series so that the pain physicians can come and learn. And we are different because all of us are from anesthesia background, and we need a little different training than probably if a surgeon would be able to if he would want to learn the same techniques, he will require different training, and we will require different training because we are more efficient than any surgeon, but probably they are more efficient in instrumentation. So and we need to upgrade ourselves, because this is a multidisciplinary branch, and the procedures are not the branch is in itself is important. Many procedures will come and go. This endoscopy is not the only procedure, but it is one of the leading procedures in our branch today. So with this vision, this society has initiated this series, and I hope everybody is finding it useful. We have tried to cover very basics, and probably which many people will take for granted, but it may be very important for beginners, or those who are just at the margin and just wanting to jump in to this technique. So it will be very beneficial for them. And we all were beginners at some point, especially me. So I have been helped by a lot of physicians. So if I can do it, I think everybody else can also do it. So I think Dr. Anurag, I think if you want to add something, please feel free to add something if you want to add.
No, you have pretty well covered it. And I would like to especially to welcome our President-elect, sir, who I can see we joined here, Dr. Viren Mohan, sir. for the meet. And I would like to welcome on behalf of Indian Society of Pain Clinicians all the delegates, especially the overseas delegates, and who have taken time. We are really happy that being the national body, we are having international friends also. So I request Dr. Ankur and Dr. Rakhi to please take over, and now we can perhaps start the meeting. Now time is 11:08. So
Okay, good morning, everyone. I welcome you all to the 6th ISPC Online Pain Gurukul. And this is the initiative by the Indian Society of Pain Clinicians. And this is the third webinar in the Percutaneous Spine Endoscopy series. So I'd like Dr. Ankur to tell a few words about Sidharth.
Again.
Hello.
Hello. Yeah, thanks, Dr. Anurag and Dr. Rakhi. I would also like to thank all the dynamic pain physicians of India attending this webinar for their courage and hard work in relieving the pain of patients during the COVID-19 crisis. Last week, we have a webinar by Dr. Devendra on how to read the MRI spine and different equipments dealing with endoscopy. Now, in continuation of that, I would like to call our speaker, Dr. Sidharth, to talk on transforaminal approaches to percutaneous spine endoscopy. Dr. Sidharth needs no introduction. As far as I know, he's a very dynamic pain physician of India who has contributed a lot in taking our pain specialty to the higher levels. Dr. Sidharth is a MD PDCC in pain, and also he did his FIPP and followed by FIPM. A lot of degrees he has achieved. And at present, he's working as an associate professor and a mentor for fellowship in pain medicine in D.Y. Patil Medical College, Navi Mumbai. He's a consultant interventional and spine and pain physician in various pain centers in all over the Navi Mumbai. As well as he's a secretary of Indian Society of Anesthesiologists, Navi Mumbai City branch, and is a joint secretary of Indian Society of Pain Clinicians. He's also a co-founder of the Mumbai Pain School, and he has got 6 international publications and 1 is patent. So thank you very much, Dr. Sidharth. And I would, you can start your presentation now. Yeah, thank you.
Thank you so much, Ankur sir, for your kind introduction and the very kind words which you have showered on me. So I'd like to start this lecture now. So the topic for today is inside out and outside in, and this is one of the topic in the series of percutaneous spine endoscopy, which is being organized by the Indian Society of Pain Clinicians, which is the society of which is comprising of the qualified full-time pain fellowship trained pain physicians of India. And this is an initiative for all budding pain physicians and anesthesiology residents, so that they can come and understand what is this branch and know more about it. So I will cover some very basic things. It is very clear that no technique can be learned on online lectures. It has to be done under a mentor, under clear observership. However, the theoretical part can be very well understood, so that the theoretical knowledge is up to date as and when you start. So why make the fuss about inside out and outside in and all these things? Because this is a beginner's dilemma. So when any pain physician starts his training in spine endoscopy, so this is his dilemma, and he gets confused often with this jargon, what is inside out and what is outside in. And this is the reason we need to make clear on the distinction and the details of these techniques. So often we ask our seniors and colleagues, or patient never asks you whether you want to do it by outside in or inside out. This is just your perspective on how you want to do the procedure. For a patient, it is just endoscopic procedure, and it is spine endoscopy. That's it. So, however, but for physicians, we may ask which one is better as far as the results, the safety, the efficacy, and all is concerned. So this is very important to understand, because there are differences in safety, there are differences in efficacies, results can be achieved neither by one but nor other, as we will see in the due course, and we will understand how the results can be achieved. So I have divided my presentation into few different topics, and that is, first I will cover the techniques, then I will cover the differences, then I will cover the video. I'll show a video with instruments and again the technique. Then I will give you a single paper, which I know that we all see papers in presentation and nobody can read. But I'm sure if you read this one paper, which is very recent to 2020 paper, I think you will come to know a lot more about these techniques. Then I will also give my personal opinion. I will discuss two cases to summarize the differences between each of the technique, and then I will end with a summary. So let's go to the technique first, the theory part of it. So the most important and step one is this pre-procedure protocol, and this is the first step which should be there in each of the patients. So this will comprise of your consent, your instrument availability, your OT booking, everything. This is more important than doing all other intervention pain procedures, because our procedures are minimally invasive but maximally risky. Okay. So if there is even a small stress in the physician's mind, you can just blow up the whole thing, because you are now not dealing in centimeters or this thing. You are dealing in parts of millimeters, because this technique uses endoscopes which magnify which give a good magnification, and as a result a small error can lead to a vast difference. Okay. The second important thing which is to be considered is positioning. So why positioning is important? Positioning is also very important because there are a lot of factors which will be different if the position changes. So if you just keep or remove a pillow below the hip, the things can totally change for you. It's difficult and you may then later on wonder why the other guy was able to do it very easily while I faced a lot of difficulties. And this positioning can be one of the factors which can make a difference. In addition, you need to consider patient factors also for your positioning. The reason being that you are probably, when you are a beginner, you may take 2 or 3 hours to do a procedure, which actually will take you 20 minutes or 30 minutes or 40 minutes later on in your career. But to start with, because you want to play more safe, you want to go slow, you want to verify each step, you may be working in an environment wherein the C-arm is difficult to manage, manipulate. So there may be a lot of other difficulties which may increase the length of your procedure. So this is why your patient needs to be comfortable, because you know what, you are doing it in the local anesthesia. And even if the patient, many times I have seen in my beginning when I was starting, so patient used to say that I'm not feeling any pain in my back, but by lying in this position, my chest has started paining, or my other body parts have started paining now, or my legs have started cramping. So this positioning is very important, and please pay due attention to this positioning. And since all of you are anesthesiologists, I think you can just read the chapter on positioning from your Miller's textbook, and it will cover very vital points which you can apply here. So let's go on the next step, which is the line drawing. I will give you a detailed description, with images. For now, you just need to remember what are the steps. So this is the third step, which is the line drawing. And then this is omitted by very experienced physicians, but I strongly recommend that you start with line drawings, because this will at the least help you understand the anatomy and make a 3D perspective in your mind. And thereafter you choose your entry point. This entry point is very important because it is difficult to change the entry point again and again. And although you can change it, there is no problem. However, you will need to do the whole thing again, and the choice of entry point is very important. So it's often, when I was beginning, the teachers used to say that, till this point you have already done more than 30% of the job, and if you can do this much correct, you are probably 30% already correct. So now the next thing is you insert your needles. The pain physicians are good with needling technique. However, we always use, we curve the needle tip, and we can just walk through the needle. And many of us are magicians in maneuvering needles from one place to the other. Here is the significant point, which is different here. Now, in this technique, you have to make sure that your needle travels in almost a straight trajectory. Why? Because your next point will be that you will be requiring to take a guide wire through it and put then your dilator and other instruments through it. So if your needle has traveled considerably in a path which is not straight, then you are more likely to encounter difficulties in negotiating the dilator through the guide wire. So this is very important difference which you need to understand between the routine pain procedures, or the MIPC as we call them, and needle position of the endoscopy. So probably if you have positioned your needle perfect, I will show you the perfect position also. So this is your 50% job done. So needle positioning is very important. Then you come up with the dilator and sleeve. I'll show you that also. Then you enter your scope and instruments, and thereafter you take out the disc and you use the radio frequency equipment to just give the lesion, radio frequency lesion, to the annulus or wherever you want, or if you have a small bleeder or whatever. And you can also put in the PRF if you want. So this is in brief the steps. Now let's see some pictures which will make them more clear. So see on this picture A here, this is how your patient is positioned. Many people recommend fixed sets which are available, but it's better just place a couple of bolsters, one below the hip and one below the chest, and just make sure that only the abdomen part is free, and give good coverage to all the other parts, and you should be good to go. Just see before starting the procedure whether your C-arm is rotating adequately to its full range of motion without striking with the table. This will make your job very easy, especially if you are a beginner. Now the point to understand here is that you make the thing whole complete AP, so you should not do the C-arm in any oblique view. Just make a 0 AP view and then just draw a line in the midline on the patient, and this is that line which is drawn. I will just thicken it. I hope you can see. Then you just make a transverse plane line which can be at the L4-5 disc level. Now the important point here is it is not required to square the disc here, because squaring will require you to tilt the C-arm to caudal position. So many people ask this, whether we square, whether we don't square. Just do it as it is, because you still will have a lot of maneuverability when you start putting your needle inside. Now you go to the lateral view and mark another 2 lines from the lateral end, and these are the lines which are shown in the picture. And the tip of your needle should lie at the tip of the vertebra, the anterior tip of the vertebra, and you should draw a line which we should mark on the skin. So this is how it will appear on the lateral side. So see this picture. So the tip of your needle is here, and you draw this line in the line of the disc. So again, just to make it clear, so this is the disc and this is the line of the disc. That is, you should not draw it like this or like this. So this is wrong. So just make sure that you are drawing it in the correct plane. So now once you have drawn the correct line, then you just measure this distance from this tip to the skin, and this distance is to be measured. It will come different for all the different levels, and it will be more as you go down. Now you see in the bottom, so this distance is now to be measured on the first line which you had drawn here, and you mark this line here. So this is the distance which you measured from the lateral view. You are now marking it on the lines which you drew on the AP view. So now you have all your markings done. Now the last step which is there is, now you draw a perpendicular from this distance to the oblique line which you have drawn, and this will give you the entry point here. If this point is not clear, there is a paper which I will quote in my subsequent slides. You can just go through and just read it again and again, and probably it will become more clear when you actually do it. Okay, so this is something which I will like to explain now. Once you have put in and drawn these lines, the first step is you put in your needle. After you put in your needle, the step is you put in your dilator. You withdraw the needle, put the guide wire, and thread the dilator over this guide wire. And this is, we are talking about the inside out approach. And once you have put the dilator, just confirm whether you have reached the correct point in AP and lateral views. Thereafter, you put in the your scope, and you are ready for visualization after putting the scope through the sleeve. Okay, so sleeve is the outer covering, which is the hollow tube that is known as the sleeve. It has a bevel. So this is the bevel as shown in the diagram. And just see, this is the area of vision which you will achieve. We use a 30-degree scope. So through a 30-degree scope, we can see what is directly in front of the you can say camera, and at an angle of 30 degree to it. Okay, so probably if you are seeing something in the screen here, so it is probably lying here, that is at an angle of 30 degree. So I hope this much is clear. Now let's see what is the theory and how it works. So you can see on MRI, this is your disc herniation, which is compressing the thecal sac and also probably the traversing route and part of the exiting route. Okay, so once you are inside this disc, now you see you are inside this disc now with the help of your instruments, and you can see this nucleus pulposus. This forms the lower portion or the floor, and you can see this annular tear through which this disc has herniated. This will form the roof of it. So this is very important, because once you understand this anatomy, what will be the floor, what will be the roof. Floor is what is down, roof is what is in the top, and this is one end, this is another end. So once you are standing, you will orient yourself whether this is the cranial end or this is the caudal end or vice versa. So this orientation is most important, and it will come not by visualizing. If you are not understanding it completely, don't worry. It will come only once you start doing the procedures under direct supervision of somebody who is experienced. Okay, so this is how the technique goes. Now this is a cadaveric specimen. It shows this approach. So you can see this is facet. This is the, you can see my markings. So this is the cranial end. This is the caudal end. So this is the foot end, and this is the head end. Okay, so this is the head end where I've marked X, and just you are standing on the right side and of the patient, and patient is lying or the cadaver is lying prone. And if you can see, this is the facet, this is the nerve root which is exiting from here, and this is the thecal sac with all the contents, and this is the traversing route which is going, and this is the exiting nerve root. Okay, and this is your scope which is going from the transforaminal foramen. That is so now once you enter from here, so these will be the structures which you will see in the endoscope or in the camera view on this screen. Okay, so this is another picture which illustrates the same thing. So if you can see, this is the outer sleeve. This one is your dilator is definitely out, because otherwise you cannot put in the scope and the instruments. This is the instrument which is inserted through the sleeve. Now if you can see, the only difference between this leveraging is that now you can, if you come out of the disc, you can also move your cannula and you can mobilize against the ventral facet to direct the cannula trajectory to the dorsal and ventral disc cavity. So these are a little bit advanced tips for some of you who are already doing the basic procedures. So this is inside out technique in short. I will also cover a video wherein I will again repeat the same technique so that it becomes more clear. Now let's go to the outside in technique. The things are almost the same. There is only a subtle difference, but that is what makes the whole thing different. So rest everything is same up till here. So needle end position, it is reached. The difference in needle end position is that in this case you dock your needle on the facet or on the bone which you want to ream or which you want to cut. The only thing why we prefer outside in approach is outside in means outside the disc. So you are visualizing the structures from outside the discs without entering in. You can later on enter it, but however, to start with, you are just visualizing the structures outside the disc. So the next step is reaming. So this is very important, and this is the most dangerous step also, because this is done blind in many cases. You can do it under vision as well. There are those of you who are using endoscopic burrs and have good instruments, you can do it under vision. Many physicians are doing it under vision. However, it is usually done in a blind technique, and you use multiple reamers. Reamers I am going to show you, and I have a small video on it, and I will show you the reamers. And you also, once you ream, you actually cut the facet. And this is the picture showing, probably it will make it more clear. So in while using this technique, the outside in approach, you see it is used more for the foraminal pathologies, or pathologies wherein the foramen is involved, and there is lateral recess or the foramen is involved, and you actually want to cut through the bony portion and give more space to the neural structures so that the patient can be relieved. So you see here in this MRI, you can see that the facet is hypertrophied, and it is compressing the lateral recess also, and this is resulting in the symptoms in this particular patient. So if you do your routine normal transforaminal endoscopy.
Dr. Yes, Sidharth, please start your presentation again. It has gone. Please, Martin, there is some problem. Hello.
Okay.
Yeah, please agree.
Sir, I'll share again. Yes, I can hear you. I can hear you, sir. Okay, so I think I'll share my screen again. Can you see, Dr. Anurag, can you see the screen again?
No, perhaps it is taking some time. Just
so I will
wait
wait.
a moment.
I will wait. When you confirm, then only I'll start speaking.
Yes. You have shared your screen?
Yes, I have shared my screen again. I think it should be. Mr.
Martin? No, it's not there.
Okay, let me check again.
Martin?
I think you can see it now. It is coming on.
It is coming, yes.
Yes, it is coming. So sorry for the technical glitch. I will repeat my last slide, probably.
Yes. Please maximize it also.
Yes, I will maximize and repeat my last slide, and I will. Yes. So I'm sorry, I cannot read the chat while I am maximized. So Anurag sir, please guide me if you cannot see my screen anytime.
Yes.
Okay. So
Dr. Rakhi, this is your job.
So let us. Okay, I'll address her now. So Rakhi ma'am, please guide me if it is not visible now. So I think I'll repeat the last portion of my inside out and then go to outside in again. Okay.
Inside out was completed. Sidharth.
Okay, it was completed. Okay. So I will go to the outside in. So I will repeat the technique again. So the as I mentioned, the first initial 4 points are exactly the same. The only difference is where in the needle end position, and then you start this reaming. So this is what is different here, and the difference is that the needle end position is not inside the disc, but it is on the top of the bone which you want to ream, and then you go on with the reaming methods. There are various methods for reaming, and by reaming I mean you cut through the bone. And it is not some you can say saw cutting or something. It is a very small portion of bone which is cut, and it is more or less glided through with the help of these reamers. So we can use two approaches. One is blind approach, which is done mostly, and second is under vision approach, which is done with the with the diamond burr or other burrs which are available. Endoscopic burrs they are known as, and if they are not available, you can also do it under fluoroscopy blindly. So this is the caution is required in this technique, because you need to, this is the picture showing the cannula here, but I will mark your boundaries wherein you can go through. So if you see, this is the pedicle, and you should not cross the medial pedicular line if you are dealing with L4-5 or below. And as you go up, this limits, it starts moving laterally. This is because the thecal sac is positioned in such a way anatomically, and you should know your limits and confirm it in AP and lateral views, and then only you should go for reaming. So what reaming does is it gives you extra space. So if you can see in this particular MRI picture, so the facet is hypertrophied, and no matter how hard you try, you probably will not be able to reach the pathology here, because if you go too lateral, you will go through the kidney, and here it is abdominal contents are lying here. Or if you go too oblique, or if you decrease the angle, increase the angle, then what will happen is that you will reach the center of the disc. Why? Because this facet is hypertrophied. It will not let you go to the correct point with the usual approach. So in such cases, the reaming is often necessary, and that is where the outside in approach comes into play. And this is this diagram is clearly showing, this is the indication, then this is the AP picture, this is the lateral picture. So you see it is not towards the disc here, so you can see that it is just above the facet here. And once you see this, then you can do so this portion is the bony portion, which has been burred, or which has been worked upon. And then after that only, this is the end view, means all the job has already been done and it has been removed. And the nerve root, you can see the S1 nerve root here, which has been made free. And this has to be done under vision. Why? Because even a slight error can lead to catastrophic consequences. Okay, so once the burring is complete, everything is done under vision in all cases, even of outside in. So you do, the only blind part is the burring part, and that too only with people who are working with limited instruments. The rest of the portion, they are same. Once you are inside, you can put a dilator, you can put scope, instruments, excision, as I will show in the video. So now let's come to the last portion, which is which I will like to emphasize, and this is the hybrid technique. Now nobody told you, or God hasn't told us that you can't do both techniques in one patient. So once you have done all the foraminal work, and if you feel that disc pathology also needs to be addressed, so after the after accessing the disc through outside in approach, you can simply go inside the disc also and do your job there. So there are certain pathologies which are to be addressed from inside the disc only, and this can be done by a hybrid approach, wherein you first access and treat the foraminal component, and then you access and do the intradiscal work. So this is what probably your learning curve will look like. So maybe you'll start with an inside out approach, do some 20-30 cases, gain some experience, give good relief to the patient. Patients are also happy, you are also happy. Then you start tackling this outside in patients also, the patients who will require this approach, and then go on and do a hybrid approach. Or if you have a mentor who is constantly with you and is very experienced, as I was fortunate, so you can straight away start with outside in approach, but then you need correct hand holding for each and every case. Your physician colleague should be supervising you for patient safety, because that's the most important part. So let's go to another case which will demonstrate this thing as well. So here you can see there is ligament flavum hypertrophy, as well as the facet hypertrophy is there. So there are two structures now which have to be dealt, and you can see it is a bilateral compression. So this small is the sac, which is probably the neural structures are confined to this portion only, and you can see there is a ligament hypertrophy more from the left side, less from the right side, or probably this cut is like that. Many times you cannot rely the cuts as well. So you have to imagine the 3D anatomy in your brain before you are doing this procedure, and you have to stay within the safe margin. So this is an absolute lateral view, and you can see that the cannula, it is very well positioned, and it is at the correct position. It's just above the facet, so that the work can be done, and the pain physician can access the pathology. And you can see this in the lateral view, in the AP view here, and you can see that this is the line which the physician will not cross in any circumstances unless he is under vision. So if you are seeing under vision that the thecal sac is away, then you can take your cannula ahead, and we go as far as to the other end also, but that all is under vision, and this goes inside from the inside the disc. So this is very important to understand. So this is once all the structures have been removed, you can see the free L5 roots, and you can see the herniated portions, and also the flavum which has been excised. So this may be required in this particular patient. Bilateral transforaminal procedure was done, and the approach was transforaminal only, but it was done bilaterally. And these kind of procedures can be done only once you are experienced. Otherwise, just imagine what I told you in the beginning. You'll start with 3 hours procedure for one side. So then obviously your patient cannot lie for another 3 hours, for you to do the procedure on the other side also. So these are, I have shown you this because this is where you have to reach. So you can start in the beginning, start slow and go stepwise, and then you can reach the next step. So let's tabulate the key differences between the inside out and outside in approaches. So the inside out technique is totally under vision. So you are seeing each and every neural structure. You are just going inside the disc, trying. So the injury risk is not zero, but it is lower than outside in. So this is also very important to understand. It is not that the injury risk becomes zero here. So you still have to be careful, but the chances of you injuring are very less unless you make gross blunders. So it is more safe, especially for beginners. Then you have a good access of the intradiscal pathology. This is very important. Additional intradiscal painful conditions such as medial annular tears. So this is something for which you will need to approach from inside out. Unstable disc fragments. So these can be better visualized. So you may have a disc fragment which may be about to come out. So if you are not inside the disc and you did all the procedure outside, everything you did clearly, you cleaned the facet, everything, only to realize that the patient has returned back after few months or few weeks, and he will say, oh doctor, I have got again this issue of back pain. And now you do an MRI, and what you find, the nucleus has again herniated. Why? Because there was already a loose fragment which you did not take care, because you didn't go inside the disc and didn't address the pathology. And now he started bending, started moving because you made him pain free, and as a result he had again this procedure. So this can be happening. So you need to see and individualize the treatment. If you have a young patient, then it is recommended that you avoid going too much inside the disc because it will accelerate the degeneration. If it's an old patient or beyond say 45 or 50 years of age, so then probably you should clear the pathology so that there is less chances of recurrence. Now let's see about outside in. The disadvantage is that the more training is required. So blind fluoroscopically guided cutting of the facet is there, but it can be overcome by good training and strictly following the protocol. Because I have seen some of our colleagues, so what they, especially when they are learning, when they are beginning to learn, so what they do is their needle position is not perfect. So what they do is, let's give slightly more drug, but that will not compensate. So a faulty needle position cannot be compensated by other techniques like giving more drug, doing more RF. So if you are not getting adequate stimulation, but you can see, oh bony, I think it is okay, so probably they'll give it more RF, so that will not help. So similar, but you can escape side effects in those situations, but not here. Here you cannot make any error. So this is very important to understand, that blind fluoroscopically guided cutting of the facet is there. It is risky, but it can be well accomplished by achieving good training. it is the advantage that it gives you a good access of the foramen, and it is very important if you have an inflamed disc, nerve, hypervascular scar, hypertrophied superior articular process. So many of the proponents of the inside out approach, they started with inside out approach, but later on then they said that okay, we have to ream the superior articular process and there is hypertrophy, so they started with that. Then they came out to ligamentum flavum, so they addressed this pathology also. Okay, so you need to understand that you need to choose the technique according to the patient. Don't be slave of the technique, rather you choose the technique which will suit your patient. And if you think that you are not capable of doing outside in technique, there is no shame, no harm in taking help of your colleagues who can actually do it and learn in the process. You know, we all are learning, so this will be a very good point to start. So impacting facet margin is there. Here your inside out technique will not help you. I'm sorry for the background noise, so please bear with me. So superior foraminal facet osteophyte, so this also cannot be addressed with the inside out technique. Superior foramen ligament impingement, hidden shoulder osteophyte. So these are the techniques which you will easily see in outside in approach. Okay, so this is very important to understand that this technique is important for all these pathologies. Okay, so this picture will give you an idea of these pathologies, and if you can see the lines, this line, okay, let me start with inside out. So you can see the middle line, this one. So this is the line for the inside out routine approach. So you access and just graze the facet, you don't cut it, and you come inside the disc and you start your working here. You do all the work here in the pathology, whatever you want, and then you come out. This is strict inside out technique. However, most physicians, what they do is first they finish this work and then convert it to outside in approach. How, I will tell you. But let's first understand what is a strict outside in approach. So a strict outside in approach is you land on the facet here. So your needle end position is here. Okay, I'm making this dot bigger so that you can understand. And then you start reaming. So this facet is cut. Okay, so this all facet is cut, and then you go inside and you reach this foramen. So this is your main area of working. So this is the main area of working in outside in, whereas this is the area of working in out. So this is a difference. It's another which is going a little bit of lateral. So if you go a little more lateral, you can achieve the same results. However, you have a risk of entering the abdominal cavity. So this is important to be understood. So when you start, you can start with strict approaches. You can do a strict inside out, take a simple case in which you can give good results. Choose case selection is the most important. You may take 3 months to find the ideal case. That's not a problem, but please start with the ideal case, because that will help you understand. When I did, I was identifying my first case. I was a little slow, and it took me like 4 months to identify my first case after I was ready to do it. So please understand that case identification is very important. Unless you are at a very high volume center where cost is also not a problem, you will face difficulty, but don't shy away from waiting for the correct indication. So now I'll show you some videos. I think just let me minimize the screen, and I will just show you a couple of videos now. I've stopped the sharing. I'll start it again and show a couple of videos. I'm sharing my entire screen now. Dr. Rakhi, tell me. Yes, yes, okay. So now I will start with this first video which I made. I'll just shut the voice. So you can see this. This is the needle, and which we use, and this is it has got markings. It's made by a Shortec company which I use. This is the guide wire, 1 millimeter thickness, which I use, and this I'll show you all instruments. This is a dilator. This is a dilator from Richard Wolf, which I use, and you can see there are two endings, two openings on both sides. So one is for the guide wire, and that is if I want to give a drug just before puncturing the annulus. And these are the this is the dilator. This all has already been covered in one of the past lectures, but I just thought it prudent to cover this in this as well, so that for those who missed the last one. So you can see this this is an attachment which will help to identify the bevel. So I correspond the black mark with this, so that I can know which side my bevel is. So this will come handy when I explain you the actual technique. Okay. So this will help me identify which side my bevel is. Okay. So the bevel end should be corresponding to this mark. Okay. Many cannulas have this fixed. So for that, you need not attach it. So this is one of the instruments. Again, this I use a Richard Wolf instrument. So you can see this is a nucleus grasping forceps. I'll show you the tip as well. So this will help me to grasp the nucleus. So this is the tip. You can see it has serrations and it has a very good hold. So I can easily catch hold of the disc material with this instrument, and I can go along well. Now this is another instrument which I like to show you. So this is a hook. So I use a blunt hook, and this hook I have purchased from Hebar. So this I use for the blunt. Then this is the annular cutter, which is important in inside out technique, especially when I have to cut through the annulus. Now I'll show you the reamers. So these are the reamers. If you see, so they are I use 4 reamers. So start with 4 mm all the way up to the 9 mm. So this is the guide wire, and you can see how I put in the guide wire. And once the guide wire is inside, you can see the free flow, and if it is not straight, the guide wire, then the reamer will not go. And this is how it cuts, and this is how I put the back handle to attach. And you can see this is my probe, again from Hebar or Hepson, and this I use to identify the pain generator. So I just probe with the help of this and identify the pain generator. This is my scope. I use a Richard Wolf scope. And this is the entry channel where I put in my instruments. So I'll show you. This is very easy and simple. So I'm trying to cover it. The light is on, so you can see how it should go in. So this is very important. And you should test your equipment, become familiar with it before you start using it. So you can see the tip of the scope, and I will just pause the video here, and you can see this is the working channel. So here we have the working channel. This is the optical fiber from where this comes in. This is the irrigation channel. So these all channels are there, and from here the irrigation fluids comes in. And this is very important to understand for a correct technique. And if you are this is the I can just shut the irrigation flow. This is my camera attachment and light source attachment.
Dr. Sidharth.
Yeah.
Sidharth. Please, sorry for the interruption. Please, you were stuck while you were describing the working channel. So please start from there. Yes,
so I have stopped the video, sir. I was not stuck. I stopped the video myself.
But your sound was also stuck actually.
Okay. So I will start from there. Yes, sir.
Yes. So
I will start from the working channel. So this is the working channel of the endoscope. And this is the area which we, when we buy the equipment, we are already, we have this diagram. What is the internal diameter? So this is the internal diameter from here to this is the internal diameter of your scope. And you see this small round thing. This is the area from where the fluid comes in, and the fluid goes out from this working channel, but it comes in through this irrigation channel. And if you see, this is the fiber optic, and this is where this is the light source which illuminates the field of vision. So this is the shaft, and then you can see the irrigation channel. I have a valve here, so to control, and this is the light source. This is the camera. So you see this is how we detach the camera, just moving it anti-clockwise, and it just opens out. And this is how you put it in. And I think this is all for the scope. Now I have another video. So you can see my equipment. So this is I use the storage equipment, and with a HD resolution camera. So you can see, I can even see the the portions even in broad daylight. So in the patient it becomes much better. So Let's go to the next video. Probably I like to show a few things. No, this is the advanced one. Let me stick to the next one. Okay, so this is a model which I thought. So you can see on your right side is the head end of the patient. On your left side is the foot end of the patient. Just imagine. And this is the model which I will use to demonstrate these structures. And this is how we approach it through the needle. So this is the needle going in, and in the patient, if you see, I'm zooming in the structures, and this is how we go directly. If you want to go, if you hit the D, then the patient will have severe pain and complications. So if you hit the bone, you are safer. So we hit the bone. I have paused the video. We hit the bone if we want to go to the for the reaming and do the outside in approach, and we go directly in the disc if we want to do the inside out approach. So I've started the video again. So you can see the difference is only slight, but that is what will make all the difference in your technique as well as in your results. Okay. So I will also zoom in and show it with more light so that it's a little more clear for you. So just let me illuminate the field. So you can see this is the inside out. So I put on the light. Now if you go inside, you can see that this will puncture the disc. And just imagine all these ropes. These are the annulus. And just imagine the red disc, which is actually the disc material. And this is how you go inside the disc, with the help of this this needle. You'll find a lot of videos on the actual procedures. I thought it prudent to cover it in a model so that you can have a different perspective. And you can also see this how the slight change in the angle of the needle can make vast differences in your approach. So you see I think this model has made it amply clear. I think I'll just fast forward it now. Okay. So I'm just showing what different needle positions, if you change the needle position, how it varies. So now I'm removing the stillet and I'm just putting in the guide wire. So this is the guide wire inside. So you can see how patient position is important. If my model changes slightly, so then the whole thing will be disturbed. So just imagine if your patient just moves by a few millimeters of inches, if you are not fixed, so your things should be very fixed. And this is how you then put in the dilator. So this is how it goes inside, cutting through all the muscles and fascia, and this is the inside out approach. So you can see I have now put in the dilator, and on top of it I am now putting in my sleeve, and this is how I put in the sleeve. Now while putting the sleeve, it is important to understand your bevel should be towards the nerve root to avoid the injury. If you have reversed your bevel, so I'm just zooming in to show you. If you have reversed the bevel, then your nerve root can get entrapped in while you are pushing in the bevel. So this is very important, and I hope this distinction is made clear and you remember this. So once you have put in the cannula, then you can go into the next step, and the next step is to put in the scope. And this is how you have made the attachment. This is the position of your cannula, and this is how you put in the scope. You put in the scope inside, you have put it on, you have put it the irrigation channel is on, and now you'll start seeing the things on your screen. Okay, and you can then start introducing your instruments or whatever you want in that. So let me show you this last video now. Okay, but before that, I like to go in through the endoscopic view. Now this is the endoscopic view of this particular model which I have done for you. So this is the facet wherein we can land. This is the superior articular process of the facet. You can see it is articulating with the inferior articular process of the upper vertebra. This is the facet joint which you can see. This is the upper vertebra, and you can see the portion of the this is the thecal sac, and you are at the axilla. And now if you see, I will just zoom in and zoom out to show you more clarity. This is the disc, and you can see on your roof. Now I am just showing you I am inside this this working channel, and let me just show you. This is the disc material. So if you go too deep, you will see only the disc. Let me pause the video here. So now if you are too deep, you will see only the disc. This, if I have come out, you see the annulus fibers which you have to pierce and go inside. So once you go inside on your roof, that is on your 12 o'clock position. Right now you can see these are the annular fibers, and if you go further out you will see the epidural space even above the 12 o'clock position. If you go below you can see the disc material. So I think I'll continue the video, and you can see that structures which are there just to make an orientation, because you cannot do all this in actual patient, and that's why I wanted to show you this anatomy in a model. And you can see now, I'll pause this here. So this is your position, and if you are too flat then you can enter. Now this at your 12 o'clock position is not the annulus, but it is actually the thecal sac where you don't want to go. So the positioning makes all the difference, and your structures which you will see will depend on your positioning. But you can clearly see on your right side, that is on your 3 o'clock position, there is the exiting nerve root coming out with the DRG. So it is not necessary to see the structures actually to visualize it. Many times the beginners, they tell me, sir, please show us the structures, please show us the structures. So I tell them, okay, actually when I was a beginner I also wanted to do. I am a little intermediate now. So right now I don't want to see the DRG, because I want it's covering fat and the other tissue which is covering it to remain so that, you know, I don't damage it and I do not cause the post procedure complications which can, you know, result from this. Let me further play the video, and you can see this structures again. I will also show you how the structures will look when you are inside. So now we are going more inside. So we are entering the disc portion. Now you can see on my this is the view wherein on 12 o'clock now you have the thecal sac, then you have the annulus, PLL, other fibers will come here. Between these two will be your epidural space, and below this, the red portion, the big one which you see, this will be your nuclear material or the disc material. So let's go further in this video. So you can see, so now the more I am inside, now look at this video. Now at your 12 o'clock is only the annular fibers. So this is the roof of your field now, and you only see the annular fiber. So at this point I will like to cut the annulus after under vision, so that I see that I don't cut the thecal sac. Okay, so because above this is epidural space and then you have the thecal sac, so you have a significant amount of play in the normal anatomy, but in your patient the anatomy will be distorted, so anything can be there. So just to be safe, cut everything under vision. Okay, so let me play this. So you can see I can go inside.
Please pause yourself, Dr. Rajesh.
Your screen, you can see the annular fibers. So this is how I will like to position my annular fibers while I cut them, because then I can approach them through my instrument and actually cut them. Okay, and if you see, this is now your epidural space and the thecal sac. So when we were away from these structures, you see we could not identify the epidural space. The two structures were, you know, found very close, but now you can very well see that in the middle of your screen, all these fibers, these are the annular fibers, and on the top is the thecal space, and in between is the thecal sac, and in between is your epidural space. So you will find the characteristic epidural fat coming out, which you can see in many videos. They're all available online. I think many of you would have seen it already. So now let us go again further deep, and I'll show you how to cross over to the other side, how easy it is, you know, if you know the anatomy, how you can go and address the pathology even in the midline. So this also can be seen and accessed. So just let me go inside now. Yeah, so I will just probe it a little more and try to go inside. So just see, this is my hook. I have put my instrument, and with the help of the hook, now I am maneuvering this cadaver. So I can push the nuclear material. I can maneuver whatever I want. But for all this, I need to be sure of my MRI anatomy. So I will like to discuss with my radiologist, ask him, take the opinion of my colleagues. I will ask often Dr. Anurag or Dr. Manish. I will call them and ask up, and, you know, take their opinion. So whosoever is guiding you, take their opinion, and don't go near the thecal sac. It's not important to see the thecal sac. So just stay in your boundary, and probably you can do things in a much better way. So let me just push it fast forward. I think, yeah. So now I will show you the recesses. This is the DRG. Again, a closer view. I will show you how you can address different pathologies by this approach. Now we are in the foramen. So if you're outside in and you have cut it, now you can cut this portion, this lower portion, and go for an inferior migrated disc, you have to cut this portion, which I am showing with my hook now. So if you cut this portion with a burr or whatever, you can address the inferior migrated disc. And if similarly, you can go up and address a slightly superior migrated disc, but your trajectory has to be done accordingly, because this is a model. The maneuverability is very easy, but in the actual patient, the maneuverability will be a little difficult. Okay. So this is how I have shown how you can just move around and address the different pathologies. So your plan should be very well clear before you access, because on that plan only the whole procedure will depend. So I think I can just forward it. Okay, so this is, I am going to the other side. You can just see, and I can just go inside, pass through this structure, and now I am inside the disc. So, and on my top is the annular roof, which is protecting me from damaging the neural structures. And slowly I am progressing and going to the midline, and many times to the other side as well. Okay. However, to the other side, if you are trying to go, and then your herniation should be placed correspondingly. I think I have tried to demonstrate with the help of this video some of the things which probably would not have been otherwise clear. So now let's go to the next portion of the slides. So this is what the literature says. So don't confuse yourself with a lot of jargon, because I know that the advanced people have not come here for the lectures. They are just for my guidance and to help me. But for those of you who are starting or you are planning to start, please understand there is good efficacy with both. Don't be a slave of a technique. Try to learn a particular technique safely, and then try to master it under supervision, and you should try to use it for the best benefit of your patient. Your aim is not to master technique. Your aim is to give the results to the patient. If you can give results to your patient with a transforaminal epidural MIPSI, so just an injection, so then definitely you are most welcome to do that. Don't go for any advanced procedures. But if you feel that your patient will need this technique, probably you should go ahead with this. Okay. So in literature, I could find one strange thing, that there are lesser same level repeat procedures with a pure inside out approach. However, you should interpret this in a different light. Maybe inside out technique, the indications are very different. So probably there will be less number of repeat procedures any which ways in those procedures. And as a result, maybe this difference in literature is there. But I'll give you my personal view in the next slide as well. So let us see about the strategies behind the inside out and outside in endoscopy of the lumbar spine. So this paper, please, if you want, you can click a screenshot or just Google this, and you will find this is a very excellent paper, and it is written by a specialist who does inside out more than outside in. But even in spite of this bias, he has been able to put forth a very good perspective for the beginners, especially because he has mentioned what beginners think and what they should not. And I found this paper extremely useful. So I refer you all to just today after the lecture, just go and study this paper by Lewandowski. And many of you must be fortunate. He was there at SIP's platform to just share his views some days back. So I think you study this single literature, and it will give you good opinion about the same. Now let's talk about my personal opinion. So I have been working in this field now for last 5 years. Exclusive pain practice I am doing, and for the last 1.5 years, I think I am doing endoscopy. And I think it is better if you learn both the techniques and individualize it to your patients. And I was fortunate, I had good guidance, so I do hybrid as per the case requirement currently, which all of you should aim to do. And the most important portion is that we should aim to be result oriented, which will give maximum satisfaction to your patient, and also increase your practice as well. So 2 examples I am taking from my personal cases, and these are the cases. Both of them I am going to do procedures the next week, and hopefully with the COVID situation also, because they are not getting benefited or getting cured with the usual conservative methods. So we have given them an option, and we are wanting to proceed ahead with these procedures. So just see the first MRI. If you see clearly that it's a disc herniation here. As per the radiologist, it is L4, L5 because they think that this is the sacralized portion of the L5 vertebra. And this is the one of the views. If you see the other view, so this is the axial cut. So if you see this, you can see that there is a herniation in this portion, okay, and it is also extending to the midline, okay, and this can be approached and treated. This has to be done transforaminally, but you see here the facet is like this, okay. So until or unless, if I am coming like this from here, so until or unless I go through this facet, so I may not be able to do this. However, if I were a beginner, I would have tried doing it with pure inside out technique, and probably the patient would have got a result also. But the post procedure MRI picture, now I have made it a protocol to do a post procedure MRI on day 1 of the procedure, and probably this has helped me to increase the longevity of the success in the procedure. All the patients, if you are doing a good inside out approach, even if you do an incomplete decompression, still they will have good relief, because you have even a 1 millimeter of space which you have given to the patient here will result in good symptomatic relief. So however, the problem is that you have to see on a whole. Like this particular patient, if you see, it is a 43-year-old female, and I will like to give her a little long-term relief so that she can, because all her other discs are well hydrated, and they look pretty well, if you see in the past slide also. So this one is only desiccated. If you see this, these all are all good. I could see some fatty infiltration, some infiltration changes in the vertebra. So I have ordered the serology. I have done with the CRP to take precautions, against any infective etiology as well. However, in this particular patient, as I mentioned, my approach will be to just land on the facet, do slight reaming here, and probably go and access this herniated portion of the disc. And you can see this here. It is again, it is through 3 cuts. So each cut, if you think that it is 0.5 centimeter also, so it's a big disc. So I'm expecting to find a big disc here. So let's go now to the case number 2. So this is a very different individual, and a different case as well. So you can see there are multiple levels are involved. So this level, this level, this level, this level, all are involved. Only one disc is hydrated. This disc and this disc. These are hydrated. Rest all these discs are dehydrated discs. You can see them all black. Okay. So these are all black discs. So these are dehydrated discs. And at present, the symptoms corroborate with L1, L2. So he has the anterior thigh symptoms, that is the lower back and anterior thigh symptoms, which corroborate with this disc seems to be the pathology. So we have offered him a diagnostic procedure, which coupled with endoscopy as well. Now let's see the other cut. So this is the same picture in further magnification. So you can see that all these discs are desiccated, and you can see this is the L1-2. There's a protrusion here, but if you see the L2-3, so this is the L2-L3. So this you see this is a big bulge here, and this extends across many sections as well. So this is the axial cut. Now if you see, the pathology is there at multiple discs, but right now the symptomatic one is very clear, that is this L2, L3, which is symptomatic and causing more symptoms. This is a magnified view, and you can very well see here the disc pathology, and this patient can have good results with this procedure. Now just see how difference the level makes. Now here you can barely see the facet, so you can see the facet is there. This is the clear view of picture of the facet, but there is a slight fluid also, so the patient is having you can see this fluid tinge in all the levels, different levels. and so the patient is having facet joint hypertrophy at most of the portions, and at our center we combine it with the cooled RFA of the facet as well at different levels, so that the patient has relief from the dull aching pain also, and he can quickly do the rehabilitation portion of it. And this is how I will like to approach. So probably my trajectory, so you can see this is all muscle, and my trajectory will be probably something like this, and I will like to address the pathology here. And you can see that this intensity zones are there in the disc as well. So prognostication has to be done. Patient has to be explained that this procedure will be a journey with you, because there are high chances of prolapse because of 3 reasons. One is he's around 52 years of age. Another is this patient is having multiple disc levels. Another reason is he's also having multiple desiccated discs, which are easily seen on the MRI. So to summarize, the procedure and technique must be practiced under supervision and perfected. You must know the risks and benefits of each technique and use it. You should individualize and choose the technique as per the pathology. And the most important thing through which I have benefited the most is record and audit your results. And of course, everybody here is there to help, so probably everybody will help you. And with these words, I thank you all. And and if there are any questions, you can just reach out to me. And we have our clinic at Panesha at Chembur in Mumbai. We do offer a full-time 1-year fellowship, and our next fellows will join as soon as the COVID situation is over, probably the next month, as the lockdown is already eased. And we also run a lot of educational courses. And thank you all for listening to it. Over to you, Rakhi ma'am. If there is any questions, I'd like to take them now.
Thank you, Dr. Sidharth, for the comprehensive coverage of the topic. I would like Dr. Ankur Jain to give his expert comment on the same.
Thanks, Dr. Sidharth, for a very useful and knowledgeable presentation, which I think will be helpful to almost all the pain physicians in India and international physicians also in upgrading their knowledge. And probably it was one of the best presentations that I have ever seen. I would like to now invite Dr. Rakhi as our moderator for the question and answer session. Thank you.
Okay. Okay. So we have a few questions here, Sidharth. People will like to know, Dr. Anup Gupta will like to know, Datta would like to know that, would like to know about the line drawing again for the entry point.
Okay, so I will put up that again. Hope I have time I can take to answer if I already.
Your voice is cracking, Sidharth.
So I hope I have time so that I can just take the screen, and I can just yeah. So I will show. So I have taken over the screen, and I'm just showing you the line drawings for this. Okay, so let me put it on full screen. Can you see me full screen now? I think.
Yeah.
Let's go to the line drawing picture as well. So you need to draw 5 lines. I will just summarize this so that it's very clear. Last time I was detailed. So line 1, AP view, midline. Can you see how I've drawn this? Line 2, if you are drawing for 2 discs, these 2 lines you draw at 2 disc levels. If you're drawing for 1 disc, then it is only 1 line. So for sake of simplicity, I'm drawing only 1 disc, 1 line now. So start again. Line 1, midline, passing through the spinous processes. Line 2, transverse, passing through the disc space. Line 3, move the picture lateral, and your needle tip should be at the tip of the vertical end, at the anterior vertebral margin, and your axis should be just the axis of the disc. This is the line 3 which you draw here. The next step is you measure the distance from this tip to the skin. This distance you mark as distance X, say for example. Next step, on this second line which you have drawn here, this was the second line which you drew. So you have drawn only 3 lines now. This is 1, this is 2, and this is the 3. So on this second line, we have now marked this this distance which you have calculated from the line 3, and you mark it here. So now from this point, you draw a perpendicular intersecting your line number 3. So this is that perpendicular where they intersect. That is your entry point, and your needle direction should be towards your pathology. So if your pathology is towards the center of the disc, so your needle direction should be towards the center of the disc. If it is towards the paracentral, it should be paracentral. It is foraminal, the needle tip direction should be foraminal. So because the end needle is meant on the pathology. So I hope I have clarified this on the
Definitely. The next question is, please describe once again about the sleeve insertion. Basically, they want to know about the procedure.
Okay, so let me take you to the procedure now. You can still see my screen. I have not disabled the screen. Let me go to the relevant portion of the procedure. So, I think not this one. This is probably this one. Let me just check. Yeah, so it is this one. So your patient is positioned, and then you make the marking. You know the entry point. After you have marked the entry point, you put in your needle and go inside. I am now explaining only the inside out technique. So try to go closer to the lower end plate so that to avoid the nerve comes from above. So go through the Campbell's triangle approach so that you are in the safe area. Just go inside the disc, and once you are inside the disc, confirm in AP lateral view your intuition. So the intuition should be confirmed. I will just show you what your intuition should be. And just go inside. Now you put in your guide wire, take out the needle stillet, put in your guide wire. This is the next step. Once you have put in the guide wire, then you just take out the needle. So this is just I am showing you the guide wire which has been put. Once the guide wire has been put, you take out the needle totally. And once you take out this, you make sure that there is no movement. Just see how this model fell. So if a patient moves, the guide wire, it is very important. I did not edit this video deliberately. So you can just understand if a patient moves while you are only with guide wire inside, and if you are doing an outside, and then you are gone. You have to do the thing again. Okay? And then you just go inside with your dilator. You thread the dilator over the guide wire. After the dilator is inside, you confirm again in AP lateral view, and then you put in your sleeve. Now here is the question which you have asked. While you are putting the sleeve, your bevel should be facing up, that is cranially, so that you avoid injuring the nerve root, catching the nerve root inside while you are pushing. Okay, because there is a small margin between the dilator and the sleeve, and you don't want your nerve root to be entrapped in it. So if it is the reverse, then you have more chances of injuring the nerve root like this. So don't do this. What I am saying now, don't do like this. Okay, because there are more chances of injuring the exiting nerve. Okay. So I think this is clear now.
Yeah.
We move to the next question.
Yeah, the next question is not cutting of the facet painful under local anesthesia?
Yes. So it is painful, but you can circumvent this. How you can circumvent this is you can, once you are at your needle tip is positioned properly, then you can give the local anesthetic and wait for some time. Okay. So this waiting is important, and don't increase the concentration, because if you increase the concentration, you will lose the differential blockade. So many times I have seen that the physicians, they will give first they will give 0.6, then they'll say, oh, if the patient is still having pain, so let's give 1.2. They will even give 2 then. So don't do that, because then your whole nerve root will become numb. Even the motor involvement will be there, and then if you just hit the nerve, you won't even come to know. Okay. So you want the nerve, just the nerve supply of the facet to get numbed, and not the other portion. So just give. You can go up to 1 ml. You just give 1 to 2 ml of the diluted local anesthetic, and you can use 0.6 to 5 or whatever percentage required, but don't exceed 1%. Just stay below that. And I think in some patients you will have pain while weaning. Just explain to the patient that there will be some pain. Try not to move. Or tell your anesthesiologist to give some amount of fentanyl or anesthetic if you want to give, but don't give anything which clouds his consciousness for long time, because you want him to be conscious. So I usually do the reaming, and I have never found any, you can say, significant issues with patients if you have counseled them before, if you have explained them before. If you have a patient, like once I had a patient who was saying, I don't want to go for so long, I cannot tolerate pain for so long, and I cannot lie for so long. So I did not take up that patient. So if your patient is not agreeing to lie for say 2-3 hours or so, at least for beginners, you tell the patient that you have to lie down for 2 hours, 3 hours. Okay, if you are okay with it, we'll do it. Once you are expert, like right now, I tell them it is just 1.5 hours. So, but when I started, the first patient I took consent, I explained to him that boss lie down for 3.5 hours. And I was fortunate, I was operating in a charity hospital, so he agreed, and that's how I started. So initially, you have to convince your patient well. You have to make a good team with your senior colleague. You have to make a good team with your patient as well. So local will take away your pain of the facet reaming more often than not.
Yeah, definitely. Sidharth, can we tell them about whatever local you are using from the beginning?
Yes. So I will tell procedure wise. So you'll find many procedures on the internet, and I'll tell you what local we use at what steps. So let me go to the steps first, and then probably it will be clearer. I will not show you the video. I think that is clear now. So I'll just show you the steps. So the first local is given at the entry point, and here you can give a good amount of local and good concentration also. So I will give a 2% local at the entry point without any problems, because I want my local to stay here for long. And I can even repeat this local at the entry point after I am out, and after I have given the if I want, I usually give a single stitch also. And at the end of the procedure, I give the local again. So this is about the entry point and the concentration. I use usually lidocaine, and before the procedure, and towards the end I give 0.5% bupivacaine as well in the entry point. Okay, so this is just to make my patient more comfortable. Then once I am putting my needle inside, I keep on giving the local, but this local is different. This local is 1% or less than 1% concentration, and this is only lidocaine. And this I keep on giving till I reach the facet. And this is important for me because all my instruments are going to pass through the various planes, and I want my planes to be anesthetized. Then once I reach the needle end position, as I mentioned, I give the local, which is now diluted in concentration. So I use a 0.6% approximate concentration of the lidocaine, and I give 2 ml at the facet, and then I wait for some time before the reaming. If I am going inside the disc, just before entering the disc, I will give the local, and probably I'll like to show you AP and lateral pictures so that it becomes clear. Just let me find a good AP lateral picture. I think this one is the best we have right now. So probably if I am this I'm showing you just the needle position. Ignore the other points. So this is the probably the end point of my needle. So my needle in AP should look like this, and my needle in lateral should look like this. Okay, so I should be at the posterior margin of the vertebral bodies at the lateral view, and I should be at the just inside the mid pedicular line or towards the center of the disc in the AP view. So anything beyond this is not acceptable. Why? Because if I am already entered the disc and also I am if the AP and lateral correspond completely, then you will enter in the center of the disc. So you will reach here and you will not be able to reach here. So this is important. So where I give local is just when I'm at the posterior margin of the disc. So I give a little bit of local there also, and this will act as an epidural anesthesia basically for the manipulation inside the foramen, and this will also anesthetize the annular fibers, so that when you put in the most painful point in a pure inside out technique is the point where the dilator punctures the annulus. So this point I will like to give the second local. And now let's come to the next step, where I will like to give the local. So I explained to you about the entry point, where I give local 2 times. I explained to you on the way I give a local while I'm putting in my needle. I explained to you while I reach there, then I give a local, at which point I explained to you radiologically. Now when I am entering my dilator, I've reached the same point where I gave the local, that is the posterior vertebral margin, just before entering the annulus. So at that point, I will give the local again if required. If it is painful, I just probe gently and see if it is painful. Then I have that. I remember I showed you 2 openings in my dilator. So with the help of my second opening, that time I can give a little bit of local if required. Okay. I don't give it in all cases, because in most cases I have given the local already. So in most cases currently, I am not required to give that. But when I was starting, I used to give it, because probably I was under giving the local, with the needle. So thereafter, you need not give any local, and because now you will just simply thread your, over your dilator, you will just push in your cannula, and then no local is required. I have, I think, made myself clear here.
Yeah, your points are very clear now. Okay, so the next question is the entry point different for central paracentral foraminal disc herniation? If yes, please explain the different drawing lines for needle entry for different dispositions. I think so. We have covered this.
Yes, we have covered this.
Yeah. Next question is
how the replay to see this. Yeah.
So how to prevent injury to the traversing nerve root? I think so. He wants to say exiting nerve root.
Yes. So traversing nerve root injury will happen only if you are too aggressive, or if you are just playing around in the foramen. Otherwise, if you are inside the disc, you cannot injure the traversing nerve root. Without cutting through the annulus or the roof, or you are leveraging or maneuvering too much. By the way, I have not shown you the leveraging video. That will make these things more clear. So just let me show you this video where I have leveraged. So I think no, this is not this video. I'll just show you the leveraging one. I think this is the one. No, it's the main one. Just this one is the leveraging one. Okay. So just see. So this is how you enter routinely. But now I will leverage it. Means I will use the facet as a lever, and I will push my scope up and down to access a superiorly migrated or inferiorly migrated herniation. So this is more possible in the model. In actuality, it is less possible, but it will help you understand the positioning. The single most important point in the reaching the fragment is positioning the needle before putting in the scope. After you put in the scope, there is a very slight modifications which you can do, but major modifications are done only through the trajectory of your needle in inside out approach. In outside in, you are actually free, and then you can play around in the foramen. So let's see how this goes. So this is I am moving it towards up. This is I am moving it towards down, and this is I am moving it towards the center. Okay, you can see this. This is how I am moving it towards the periphery. So again, down, up, okay, and then center, the same. And you can see there is a hell lot of a difference between all these techniques and procedures. And this if you put the instrument here also, you will understand that there is a significant leverage which you can gain through using the facet as a fulcrum. You can manipulate it a little bit and try to grab the fragment, especially important while you are doing the inside out approach. Okay.
Yeah.
So I think this point is also clear now.
Yeah, but once again, we can tell them about like how to prevent the injury to the exiting.
Yes. So while you are doing this, I'm sorry, I missed out the injury portion. So how to prevent the injury? It's very simple. Number one, there are some. If your patient is telling you is having a pain which is radiating towards his leg, and you find a radicular distribution towards the leg, then you should definitely evaluate your technique, whether you are doing something wrong or not. Number two, to avoid the thecal sac injury, you should respect the bony boundaries. So if you are doing it probably at L4-5, you should not cross the when you are crossing the mid pedicular line, you should become cautious, and in no condition you should cross the medial pedicular line without seeing your lateral picture, whether you have crossed the the thecal sac. Okay, so this is very important to avoid injury to the thecal sac with your instruments when your endoscope is not inside. Number two, you approach through the safe triangle approach or the Cambian's triangle approach. So you go towards the lower end, because at the upper end of the foramen, you will also find, so this is the upper end of the foramen, you can see on my screen here, and you will also find not only the exiting nerve root, but also the arteries, blood vessels is also there on the upper portion. So if you are going through the lower portion, you will avoid, you know, the injuring these vessels and the neural structures. Another point is that you avoid over irrigation or going too close to the DRG and manipulating it. So this can also result in nerve injury, which will manifest later on, and your patient will have a different kind of a dull kind of an aching pain throughout, and it may result in burning also. If you have burning pain after the procedure, which was not there before the procedure, so just think in your mind that you have caused some sort of an injury to any of these nerves, or especially of the DRG. So there are various syndromes also which are mentioned. Now let's go on to the somebody was asking traversing nerve root. So it's very difficult to injure traversing nerve root with an inside out approach. It's actually, you'll have to do a lot of blunders to go there. But if you are working with inside out approach, so then it is you know, once you are inside the disc, you cannot injure any nerve structures. While cutting the annulus, you have to be careful that you don't cut any neural structures. So I think if you follow these simple steps, you will be pretty safe. And to start with, just have somebody watching over you, so that if you miss something, you have some guidance.
It's a wonderful explanation, Sidharth. Okay, Dr. Prasanna wants to ask, what's your opinion on ozone discolysis? Is it really helpful?
I think this is not related to the topic.
Right.
Yeah, I think we should take this. Yeah. I never done any ozone in a disc in my life, and I am doing pretty good. So I think in terms of patient relief, my patients are happy. So I don't think definitely you can do without it.
Yeah. So what is the Dr. Singh is asking, what is the long-term evidence via vis-a-vis single level discectomy, functional gains, and failed back surgery?
So, ma'am, can you repeat your question? Long-term evidence versus?
Long-term evidence vis-a-vis single-level discectomy, functional gains, and failed back surgery.
Yes. So, you can see there is a lot of evidence which is available on different, even meta-analysis have now come up. And I will speak in terms of the, the transforaminal approach and, its consequences. So the disc degeneration process, it has to be understood as a whole. So many people have described, usually surgeons have described it as a 7-stage process. Some say it is a, it is an ongoing process, and once it starts and then it will progress only. There is no way to stop this progress or something like that. But I will like to talk here about the transforaminal procedure. This procedure is actually beautiful because you can repeat it n number of times. If you see the incidence, there is no other procedure which you can repeat it, to address any kind of a pathology and minimize the risk or damage to cause to the disc as well. If you combine it and do a hybrid procedure, you can do as little as possible. If your patient is cooperative, you can tell them, boss, I am going to do very little as necessary, and if required, we can always do a future procedure which can be good for you in the long run, because you want to avoid the degeneration. Plus, now many of the physicians have combined, and surgeons, they have combined the regenerative therapies with this procedure. So after doing all the debulking or after addressing the pathology, what they do is they put in some sort of regenerative fluid there, which many physicians have put, PRF, which is a platelet-rich fibrin plugs, or many physicians, they put in the BMAC aspirate. So many physicians, they put simple PRP. So many physicians, they are putting nowadays exosomes. So there are a lot of different things which are tried, and the evidence is very clear on this fact that after the inside out approach, the incidence of complication greatly reduces. The efficacy and other level discs, the procedures, they are rather same, but the incidence of post procedure complications or failback has reduced with this thing, at least in the short term. Now talking about the incidence of discitis also is comparable in all the transforaminal approaches as well as the open surgical approaches. So in terms of efficacy, many physicians, they say that or many surgeons, they advocate the microscopic discectomy also. But I've seen a lot of papers, and most of them, they say that the efficacy is almost the same, but the morbidity or the post procedure rehab or the incidence of the complications is much lower in these minimally invasive endoscopic procedures as compared to the the procedures which are done by an open method or a semi-open method or a smaller incision or likewise.
Great explanation, Sidharth. So now there are no more questions in the chat box now. So we can, I think so we can wind up the presentation now. Okay, thank you, Sidharth, for the wonderful presentation. Thank you, Dr. Ankur Jain, sir. And thank you, Anurag, sir, for this wonderful initiative. And thank you all the participants who have joined with us. We have had a good number of participants in the presentation. Thank you all.
May I come for a moment?
Yes, sir.
Yeah. So I am really thankful to, on the behalf of Indian Society of Pain Clinicians, I am thankful to Dr. Ankur Jain, who has taken his precious time to coordinate this session. I am thankful to Dr. Sidharth Verma, who has given a wonderful presentation, especially his indigenous videos, which I believe that must have helped a lot for all to understand the basic idea of transforaminal spine endoscopy. They were made especially with the keeping in the mind of the understanding of the pain physicians. So they were amazing. Apart from that, I am thankful to Dr. Rakhi for a wonderful moderation of the session. She has done it remarkably smoothly and with the clear thoughts. And also I would like to thank and say a word about the MedWiz, this online platform which we are using for our ISPC Online Gurukul. This MedWiz platform is an indigenous platform which is being developed by a group of doctors. So we thought, why should not we use this platform? And it is a wonderful platform, as you must have felt by now. That sound quality is good, video quality is good, you can share, you can save your screen, you can have the videos recorded, everything pretty much you can do, which you can do with any other platform. So as Indian Society of Pain Clinicians, I request to all my friends to use this platform for their own programs also. And this webinar as well as the next webinar, we are as a society thankful to Intas Pharmaceuticals, who have supported us and powered us enough to so that we can run our program without any hitch. So over to you, Dr. Rakhi and Dr. Ankur and Dr. Sidharth.
Yes, sir. So I would like to thank everybody, Dr. Sidharth, Dr. Ankur, Anurag, sir. And like
just a moment, Dr. Rakhi, I am coming in between again. I am very happy to see Manish Raj here, who is one of the pioneer of percutaneous spine endoscopy, as well as Sushil Jaiswal in the group. So we are really indebted to these two guys in India for making spine endoscopy possible and popularized and easy for most of us and all of us. So I would like to welcome all of them also, and we hope that, as Sidharth has mentioned in his last slide, that our society and our group is there to help all our fellow pain physician physician colleagues to start, and we are there with them throughout their journey from the start to the finish. We want them to embrace this technique. We want them to we are here to handhold them for everything they do in their life with the endoscope. So be it. Sorry, Rakhi, I interrupted in between
No, sir,
again.
not at all, sir. You,
Please.
you are a guiding teacher, sir. Today's Guru, Verma, and we have learned a lot from you, sir. Okay, so I'd like to end the session now, sir. Presentation.
Yeah.
By thanking everybody.
Dr. Ankur, would you like to say a word?
Yeah, it's a very nice presentation today, and it's a very good platform that we are using for the at one single platform. We are here sitting with all the pain physicians of India. It's a very nice thing, and wish you a very happy good Purnima today. And I would like to wish all my mentors and all my guide to have a very good Purnima from my side. And thank you very much. Thank you very much.
Okay. So now we are ending the meeting, Sidharth. Thank you.
Thank you, sir. Thank you, sir.
Bye. Happy Guru Purnima to all, and keep safe, keep healthy, and keep on working. Bye. See you next week in the last, perhaps second last lecture of the percutaneous spine endoscopy. This lecture will be by Dr. Sushil Jaiswal, who will talk about the interlaminar approaches. Again, keeping the understanding of pain physicians in mind, and it will also be a great eye opener for all of us, I believe. So see you next week, same time, same platform. Until then, bye.
Thank you. Thank you. Bye.
Thank you, sir.